Good afternoon, everyone. This is Christine at Health Current, and thank you for joining us for the EPCS Controlled Substances Prescription Monitoring Program, CS PMP Requirements, Benefits, and More webinar. This presentation is provided through a shared commitment between Health Current, Arizona Healthcare Cost Containment System, ACCESS, and the Department of Health Services, ADHS, and the Arizona Board of Pharmacy to manage and coordinate the statewide EPCS Click for Control education campaign. Just a few logistic reminders today. This session is recorded and will be posted to the Health Current website. We encourage you to use the chat box for question or comments. And please do not hesitate, and please do not include your name, practice, organization, or submit any patient health information or PHI. All lines will be muted. Connie, are you with us today?
I'm with you.
Wonderful.
Thank you, Christine. Today I have the honor of introducing our webinar presenter, Lynn Curtis, who is the CS PMP Marketing Specialist for our Arizona State Board of Pharmacy. Lynn has a wealth of knowledge to share about the CS PMP requirements, benefits, and much, much more, including some features that I'm sure most of you will be very interested to know. Lynn, please begin your presentation.
Connie, thank you so much. And Christine, thank you as well. Is my mic okay?
It is, Lynn. Thank you.
Yeah.
Excellent. Okay. I don't want to start babbling and not have anybody hear me. Well, I want to thank Health Current for giving me the opportunity to be with you today, spending about an hour with you talking about CSPMP and the EPCS. We have quite a few things that we're going to cover. I think it's going to be a good hour. It'll be a valuable hour for you. Just a reminder again, you can, if you have any questions during my presentation, please feel free to put them into the chat box. I do have my slides numbered, so if there's a particular slide that you want me to reference, you can put that number in there as well. Also, if there's something that
helped us manage through this crisis. And last.
And also, if there is a question that might be a little bit more in depth, or maybe something that I can't answer, even though Connie puts a lot of pressure on me to know a lot of it, I will post my email at the end of the presentation, and you're more than welcome to reach out to me anytime for any questions you might have about the CSPMP. So with that, let's go ahead and get started and talk. First of all, let's talk a little bit about what we're going to talk about. There we go. So I'm going to talk a little bit about the PMP, of course. I'm going to talk about some of the statutes that are around the requirements of using the PMP. We like to make sure that folks are using it the right way and that those that need to use it are using it. So we'll talk about that for a little bit. We do have a new feature that is a couple months old with the PMP, which is called clinical alerts. And for those of you who are practitioners, medical practitioners that use what I'll call the CSPMP from here on out, the PMP, that's how I refer to it, the PMP. You've probably received these clinical alerts when you are looking up a patient utilization report. So we'll talk a little bit about those. I will review some of the EPCS exemptions that are available, and even though EPCS right now, the requirement has been suspended through the health emergency that we have, it's still always good to keep those refreshed in our mind. I will also hit on some COVID-19 updates as regards to the pharmacies and what the pharmacies are doing. And I've picked these rules and updates that I believe affect not just pharmacists, but medical providers and the public as well. And then I always like to end with some additional tools and resources that that will help you if you have any questions, but also things that will help you when you are working with controlled substances. So with that, let's go ahead and dive right in. So let's talk about the PMP. The PMP, it's a database that tracks controlled substances that are dispensed. And so the majority of the data that goes into the PMP is uploaded by our pharmacies. And that's the reason why I work for the Board of Pharmacy. There are a group of dispensers that are prescribers that do dispense controlled substances out of their office, and they have the same requirements and reporting as well. The primary use of the PMP is really to help prescribers and pharmacists help their patients. It's just another point of data that they can turn to when they're making decisions, the best health decisions for their patients. A couple of fun facts about the PMP. It's been around since 2008, so we turned 12 this year. There is a PMP in every state of the United States. Every state has some form of a PMP. The lone outlier is Missouri. They don't have a state PMP, but St. Louis County, which is the largest county in Missouri, does have a PMP. Right now, we are connected to 36 states. So we're not connected nationwide, but we do work at getting connected. One of those 36 states is actually the military health services. So these are the bases, these are combined, and they are considered a state, so to speak. The PMP, the Arizona PMP is connected to all of our border states except for California. And this is a big gripe that a lot of people have. We continue to work with other states to get connected. The thing that holds back those connections really are statutes, what we can share and what we can't share. And so the states are working hard to make it work, reaching out to each states, and after each legislative season, if we do have any changes, we make sure those communicated to other states that we're not connected to, and hopefully we make that connection. Just a couple of things. In 2018, we had over almost 4 million queries for the Arizona PMP. So it is a large database and it's used a lot. So let's go ahead and talk now about the main report that is in the PMP. This is what medical practitioners and others typically would use when they are, not typically, when they are treating a patient. This is the report that they would pull up, the patient utilization report. And I want to go through this really quickly. This is a sample of what it would be. By default, when you access a patient's utilization report through the PMP, it will give you a year history of controlled substances that were dispensed for this patient. You can access a longer time if need be. You'll notice that the first section is called linked records. This is basically all the different prescriptions that have been dispensed for a patient that include maybe a different name. You might have a Becky as opposed to Rebecca. They might use those interchangeably. And also, we move around. We have different addresses. The addresses are required on prescriptions. And so that's why this linked records can build, and you could have multiple records in there, even though it is only one patient that we're talking about. When you are searching in the PMP, there is, you can do a multiple patient request, and that's where you would put in like a Becky and a Rebecca, and that would pull that all up. You can also do a partial name search as well. In my presentations, I don't really get into the nuts and bolts of using the PMP, only because we have some really good short training videos that are on the website that I'll talk about a little bit later. So again, I'm just sort of doing an overview and kind of give you a sense of what it is. The second segment is the summary segment. This will let you know how many prescriptions are in the report, how many prescribers and pharmacists are involved with those prescriptions. There is a 30-day summary of any opioids or buprenorphine prescriptions that might be active. And again, this is information that you would use when treating a patient. This is the heart of the report. This will give you a list of the prescriptions for the patient. And just very quickly, you can see when it was filled. The ID, of course, connects back to the patient section. When the prescription is written, what the drug was, the quantity, the days. It will give you information about the prescriber and the pharmacy that filled it, which is useful if you need to go back and you have any questions about past prescriptions, and of course the prescription number itself. It will also give you the refills that are available, as well as which state that you pulled the report from. Again, you can go in, and if we're connected to a state, you can search other states other than Arizona. This is useful, of course, because we have a good portion of our population that will spend winters here, coming from other states, so that way you're able to get the best picture possible for their controlled substances prescription history. The last two sections are the prescribers and dispensers related to the prescriptions itself. And these would have phone numbers, they would have addresses, and this, again, this does allow you to go back and ask any questions you might have. So the patient utilization report is the main report that is produced in the PMP. So in early 2018, Governor Ducey signed the Arizona Opioid Epidemic Act. A lot of changes went into effect, and some of those changes affected the requirements for using the PMP. What I want to do in the next section is talk a little bit about some of those requirements, just to get a little clearer picture of as a medical professional, what you need to do to be in compliance with the PMP. The first requirement is registration. If you are a prescriber and if you have a valid license from a state licensing board and a valid DEA number, you must be registered with the PMP. We frequently get calls from prescribers that say, you know, I don't prescribe controlled substances. Do I still need to be registered? The answer is yes. We also get calls from prescribers who are retiring that want to keep their license active and the DEA active, but they don't know if they're going to prescribe or not. They still need to be registered. The good thing about the registration for the PMP is that it'll take you about 10 minutes to do. It's very easy. It's free. You don't have to pay anything, and it never expires. So once you're registered, and as long as your license stays valid and your DEA numbers stay valid, you will be registered. If you are a pharmacist and you work at a facility that has a valid DEA number and you have a valid pharmacy license, then you must be registered with the PMP. So who has access to the PMP? We know prescribers do. We know that pharmacists do. Another group that has access are called delegates. These are folks that work with prescribers and pharmacists, whether in the pharmacy or the doctor's office. They can be given access, and they can pull the patient utilization reports for the doctors and the pharmacists. So it's a way, if you've got a busy workload, it's a way that you can give access to a delegate in your office. It could be the office manager, it could be a medical assistant, it could be a pharmacy tech, and they can pull those reports for you. The licensing boards have access to the PMP, as do medical examiners. Now, you'll notice this list is, I've got it in two sections, and there is a little reason for this. The folks on the left, the users on the left of your screen, have direct access to the PMP, meaning they can go in, they can put in the parameters for a search, and they'll get a report. The users on the right have indirect access, and what I mean by that is if you are in law enforcement or a Medicaid fraud investigator, you can go in, you can request a report, but we meaning the admin team on the PMP team, they have to release it to those users. And typically law enforcement, Medicaid, they have to have, it has to be part of an open investigation. And in the comment section, when they request the report, they will tell us it is for this case, and they'll give us information on the case. Once we have that, then we can release it to those users. Attorneys will ask for PMP records. We will release those with a court order. We will not release those with a subpoena. And then finally, the public has access to their records. Individuals are able to request their reports, and you can have what you would need is there is a form that is on the web page. You can you fill that out, you have it notarized. Once it's notarized, you would make a copy of government ID. You either send those in via mail or email or fax them. Once we make sure that's all correct, then when we pull the records, then we can send them to the public. Okay, so when are we required to pull a report? For a prescriber, before prescribing opioid or benzodiazepine, you must pull a patient utilization report. The requirements are it must include the preceding 12 months, which is the default length for a patient utilization report. You must pull it for any initial course of treatment. If there is an ongoing treatment, you must pull it every 3 months. There are some exemptions to reviewing the report. If you're treating somebody with a cancer diagnosis, somebody who has had a traumatic injury and there's just not time to do it, hospice care, skilled nursing facility, and a medication-assisted treatment program. In these situations, it is not required by statute to pull the report. So pharmacists, their responsibility for when they pull a report is a little bit different, and this is something that I like to point out. They are required to review a patient report before dispensing any Schedule II controlled substance. So it's a wider net that they have to throw out there, and of course some of the same requirements as well when it comes to the length of report and when they need to pull it. So what we tell prescribers is there might be an instance when you have a patient and you're working with a pharmacist, and a pharmacist might call you regarding a question they might have about the PMP report for that patient. Just remember that they have a wider net, and keep in mind it's just an extra set of eyes that helps with the best treatment for this patient, and you are a team. The pharmacists take their corresponding responsibility seriously, and they want the best for the patient as well. So again, we hope that our prescribers and dispensers are working as a team. So there are some appropriate uses and unappropriate uses, and really it comes down to two simple rules. The first one is if you have a medical provider patient relationship, then it is appropriate for you to use and pull the PMP. And then we also talked about if it's part of an open investigation, then the access is granted. It cannot be used for curiosity. Let's say that your daughter is dating a young man and you want to check up on him or him. That is a no-no. You're not able to do that. It's not to be used for employment screening as well. So it is fairly narrow when you can use it. Keep in mind also that this is a database, so we know who pulls the reports, we know what reports are pulled, and it becomes part of your record there. If it is used incorrectly, it is a Class 6 felony, and that would be something that your licensing board would talk with you about if it was a problem. So just keep that in mind. So there are some advantages to using the PMP, and hopefully, beyond the fact that it just gives another important information when you're making decisions about prescribing very serious drugs. but it does assist in prescribing dispensing decisions. And what we're finding is that a lot of the bigger health facilities and the medical associations are starting to make it a best practice or standard of care for most situations. So it is becoming more widely used, which is what we like. Using the PMP as well will help you identify, deter, and prevent diversion and abuse of prescription drugs as well. And we've seen that with the number of prescriptions that are prescribed for opioids and controlled substances. Those have gone down. One thing that prescribers might or might not know, but this is something that we like to make sure that they do know, is there is a report in the PMP called MyRx. As a prescriber, you have access to that report. When you pull that report, it will let you know which prescriptions were dispensed using your DEA number. We recommend that prescribers check this regularly, and in case you do find that there might be a dispensation using your DEA number that might not be correct, or you feel it's not correct, you could call us, but what we do is we recommend that you reach out to the pharmacy. Remember, it is the pharmacists and the pharmacies that upload the information, and we are human and errors are made. For the most part, if there is an error that has been made, that can be corrected and it will come off your report. But there are instances where a DEA number has been used inappropriately, and in that sense, that we would have that prescriber reach out to their local law enforcement. They have teams that would take care of this. So one of the other reports that are available on the PMP. So we talked about use of the PMP. One thing that we have been working really hard on the last couple years is pushing the integration of the PMP to the electronic health record software and the pharmacy softwares. We would get a pushback from users saying it's just too difficult. I'm with a patient, I have to go to another system, I have to log in, I need to remember my password, then I have to pull all that information and put it in. But with integration, you're working with your patient and you've got your EHR software up and you're looking at that. There is a button there. Pull the button. You might have to add maybe some parameters if you want to search another state, and you would that would pull up the PMP report. So you would not have to go to another portal to be able to get that information. We have a lot of our large health entities are integrated. All of our big pharmacy chains are integrated as well, and it works really, really well. Now, the AWARE system, which is the portal that you would use, that is still available. Integration is not mandatory. It's not a statute that says you have to be integrated, but it does work really well. If you do have any information, oops, there we go, hit the wrong button. If you do have any questions, we do have an integration webpage that will give you all the information you need, and you can also contact us as well. It's a little bit of a process only in the sense of we make sure that there's some back and forth with some questionnaires, that you understand the terms and conditions, and once all that's met, then we hand you off to our vendor, who would then work with you and your IT people to get your system integrated. And again, you can see the website down below. Okay, we also talked about delegates, a little bit about who has access. And again, delegates are somebody that works with you or in your office that you've given permission to pull patient utilization reports for you. The medical provider is sort of a supervisor of the delegate in the sense of they give the delegate access. The delegate has to have their own PMP account. By statute, you cannot share your account. And so if you are an office manager and you are pulling reports for your prescribers in the office, your providers in the office, that is a no-no. You need to have your own account, and then you can go in and pull those reports for each one of those providers. And if you have any questions about delegates, there is, again, a good short video that will talk about that. Okay, we're going to go away from the PMP now, well, a little bit, and we're going to talk about clinical alerts now. So in mid-April, clinical alerts began. We turned them on for all the medical providers in Arizona. They're pushed both to prescribers and pharmacists. And what it is we have set up a couple of alerts, some thresholds that when a patient hits those thresholds or meets that criteria, then the prescriber or the pharmacist gets an alert. One thing we always tell prescribers who have any questions about it is that it is for informational purposes only. There are valid reasons why a patient might hit these thresholds. But again, it's another piece of information that you can use to treat your patient. So we have 2 active alerts right now. If we have what is called the concurrent opioid and benzo alert, this is a dangerous combination. And if you have concurrent active prescriptions, then you will receive an alert. The second alert, we call it the suspected prescriber pharmacy shopper. If a patient has received a controlled substance prescription from 5 or more different prescribers and filled at 5 or more different pharmacies within 90 days, within a 90-day window, then that alert would be triggered. There are a couple of ways, a few ways that the medical providers would receive the alert. They do have their dashboard. If you go into the Aware portal, that will give you, will let you know that there are some patients that have triggered these alerts. You will also receive an email as well. If you don't see these two, say that you're working through your EHR, when you pull up the patient utilization report, there will be a banner underneath the patient section that will give you information on the alert or on the threshold that they've met. And this is what those would look like. Okay. So now I want to talk a little bit about EPCS, electronic prescribing of controlled substances. I've worked with Health Current for quite a while with this, Connie and I. And whereas Health Current, they cover what I cover, but they cover much, much more about how to get connected and requirements and that type of stuff. What I really focus on is the exemptions from the EPCS requirement. So we'll talk about what that requirement is, and then we'll talk about some of the exemptions that are available. Again, right now EPCS is, the requirement has been lifted, although if you have an EPCS system, you know, still use it, of course. But in state of Arizona, if you are you're going to be prescribing a Schedule II opioid, then it must be sent via EPCS. And this began at the 1st of this year, and right now it is suspended, but once the health emergency is ended, this requirement will go back into effect. The system itself, there's a couple of things, the requirements for that. You have to make sure your EHR is EPCS certified, and the pharmacy software can receive that as well. The prescribers must complete an identity credentialing program, so they know who you are. And also, will use dual authentication. So you might have a token, you might have a fob, you might, get maybe a little passcode on your phone or something like that. And that just adds to the level of security when you are transmitting these prescriptions. And then again, you would be working with your EHR vendor or your pharmacy software vendor to make sure that that works properly and you're good to go. For those of you who are interested in this, 362525 is the Arizona revised statutes is where this information is at. So again, there are some exemptions, and let's kind of pretend that we are not having a health emergency right now. That EPS is still required. There are instances where EPCS system will not be operational, and the main reason why these exemptions were put into place is I should say that the lawmakers don't want to hinder patients from getting medications that they need. And so that's why these exemptions are in process, are active and written into the statutes. But again, if an EPCS system is not operational, the prescriber can go back to the pad and when filling out a paper script, they would just note on there that the EPCS is not operational. Federal facilities, because EPCS is a state statute, federal facilities are not required. These include veterans VA facilities, health facilities on military bases, Indian Health Services, and tribal-owned clinics. So if you're a prescriber or a dispenser and you have somebody that was treated at a federal facility, or maybe they're going to be filling a prescription at a federal facility that's a pharmacy, you would have to make sure that you write that and note that in the hard copy of the script. We had a lot of confusion when this first started regarding this, and so we just preach it. Veterinarians are exempt from the EPC requirement. They don't have the software that's capable of handling it right now, and that will change down the road. And again, because we have a sizable population that will come here during the winter, they will bring prescriptions for them that probably need to be filled. And if it's an out-of-state prescription, the pharmacist will be able to fill that if it is on a hard script. Long-term health care and hospice, they are able to fax the Schedule II opioid prescriptions. If it's a compound medication, the systems are just not set up to handle the compound medication, so those can be written as well. And if for whatever reason there was a new Schedule II opioid that was FDA approved, but maybe it wasn't in the system yet or the systems, if those are going to be prescribed and it's not in the EPCS system, then a hard copy is required as well. And of course, with any of these, make sure that it's noted. That way the pharmacist will fill it and not have any questions. And I will shout out Health Current right now. Again, they are your main resource for EPCS. They've got a great site. It has a lot of information on it. And Connie, I don't know if the numbers have kind of caught up with, I know we were waiting for vendors to get EPCS working and that type of stuff, but there is still good information out there that's updated regularly. So now I want to talk a little bit about COVID-19. And when I talk about this, I'm going to talk about it again, how it affects and the rules around pharmacies. If you're a medical professional, we recommend that you visit your licensing board regularly. They'll have information, updated information, that type of stuff. We keep our website up to date with as much information as possible. When this first started, we had a task force that would meet regularly and would discuss rules and situations and how that would all play out and what we needed to put in place to make sure that things worked well. Pharmacy is pharmacies have to stay open. Folks have their medications. We wanted to make sure that we made that work and made that possible. What I want to do is talk a little bit about some of the new rules that are put into place, or temporary rules that might affect the public or the prescribers. If for whatever reason a pharmacy needs to close, they need to notify us, the Board of Pharmacy, and then they are also required to communicate that to patients and prescribers. So if you are a prescriber and you're in an area that might not have a lot of pharmacies, that the closure will be communicated with you, and the pharmacy should have in place how to transfer and fill those prescriptions. Also, if there's a change in operation hours, that needs to be communicated as well to the community and to the health professionals that use the pharmacy itself. We mentioned this before, but EPCS is not required right now, so a handwritten script is still allowed, and those can also be phone, faxed, or scanned to the pharmacy and sent to the pharmacy, with the original being kept by the prescriber. Consultations have changed a little bit. Usually, instead of the face-to-face requirement on some prescriptions, especially new prescriptions, it can be done over the telephone now through the drive-through or other technological means. And then also a signature of the patient is not required. And again, these are rules that have been set up for the health emergency. There is also work by remote access that is available to both pharmacies and technicians. And there's a lot of requirements for that. So we do have a very extensive FAQ section on our webpage. So if you want more information on that, then you would, I highly recommend going there and reading through that. The Board of Pharmacy has given pharmacists, they can dispense a quantity that's greater than prescribed, and this is around maintenance medications. Initially, it was difficult, and sometimes it is still difficult to get a hold of prescribers. So pharmacists are allowed that. They're also allowed to do refills, and we just ask them to exercise their professional judgment. But if there are instructions on that the prescriber has, then they must follow them. We also recommend that they try to reach out to the prescriber before they do the refills and dispensing a quantity greater than prescribed. And this is with our licensure for the pharmacies. These have kind of been pushed back, and you'll want to refer to the FAQ because this has changed, not regularly, but of course, as we are going down the road of the epidemic, decisions will be made and these will be pushed back. So keep that in mind. Okay, we're on the home stretch here. I want to talk about some resources and assistance that are available to you, and not just with the PMP, but with other items as well. The first one I want to talk about is the OR line. the opioid assistance and referral. This is works like poison control. In fact, it's part of poison control. It's housed, I believe, in the same area. Or it's down in Tucson anyway. But this is a free 24-hour service, and it connects both public and healthcare providers with experts that can give you, if you're a professional that's calling, they can give you, real-time consultation on such things as dangerous drug combinations or prescribing limits and that type of stuff. Probably the most important thing that they do is the referral part. Is they can provide a warm referral to statewide treatment programs. So it's a good service. It's a free service. If you're not familiar with it, definitely go to the website that they have. Just type in Orline, Arizona, and the number is there below. But it is something to keep in your back pocket if you have any questions or need any help, whether professionally or if you have somebody that personally, maybe on a personal level, that needs assistance as well. Naloxone access. In the state of Arizona, there is a standing order that was issued by Dr. Christ from our health services. And basically this is a script that anyone in the public who needs access to any of the naloxone, they can go and buy that. And of course, studies have shown that it's when naloxone is around and the knowledge of using it is around, that it does save lives. So I always like to remind people that. And then for prescribers, there is one of the things that came out of the work from the Arizona Opioid Act was a consortium of stakeholders that got together and put this prescribing guideline together for opioids. And it's basically broken down into 3 sections. There are recommendations on treating acute pain, treating chronic pain, and there's also a list of recommendations that they have when thinking about and treating prescribing pain or prescribing opioids for pain. And one of those recommendations is using the PMP. This is available on the on ADHS, on the Health Services website. If you just type it in, you can download a PDF copy of this. If you want to have a hard copy, you can also order hard copies from there as well. So it's a good resource to familiarize yourself with and to have around. I did a lot of fast talking today. I feel like I'm blistering this. And I know that we have some questions coming in that I'm going to get to here really quick, but there are other resources that I will leave you with beyond reaching out to me. We keep our CSPMP website up to date, and it has a lot of the things that are going on with COVID and the clinical alerts and that type of stuff. So highly recommend, if you have any questions regarding any of that I've talked about today, you will find information about that on our website. These are the videos that are available. It will help you with registration, how to request that patient utilization report, how to understand it. The one on the bottom right corner that's sort of a brownish burgundy is the MyRx. That talks a little bit about that report that prescribers have available to them so they can check their DEA number to make sure that it hasn't been compromised. And again, these all can be found on our website. Okay, I've thrown a lot at you. I know that there are some questions, so Christine, fire away.
Hi, Lynn. I haven't seen any come through quite yet in the chat box, but just a reminder for folks that are online, there is a chat box feature, and if you go ahead and type those questions in, we can go ahead and read them to Lynn. And oh, they're starting to pop in now. Can you clarify? Did you say that the PMP registrations, oops, they're really popping in, is required by all physicians or recommended for those who do not prescribe controlled substance?
So if you, what the statute states is if you have an active, if your license is in good standing and you have an active DEA number, you must be registered. So that's what the statute says. And again, it's free. It takes you about 10 minutes and it never expires. So that's an easy one to check off your list.
Okay. I guess if it is required, where can folks reference that information?
That is in the Arizona revised statutes, and I don't know that statute off the top of my head, but I am going to actually, let me do it right now. If you want to send me your information, whoever asked that question, find that for you and send it to you.
Okay, wonderful. Another question that came through is, do delegates need to be a certified MA? If you work in a prescriber's office, there's no requirements for licensure. It could be an office manager, it could be an MA, but if you work in a pharmacy, you must be licensed. So you must be a licensed tech. They would have access to it because they have a license. So I don't know the requirements for an MA being certified, but an office manager can have access. So I don't believe you need to be certified. Okay. And Lynn, if you hover over your presentation, you might get some radio buttons that pop up at the top. One of them looks like a little conversation bubble.
Oh, yeah.
You may, if you can click on that, you may find that some folks have come in questions have come in privately to you.
Oh, okay.
Kind of pop up on the chat. So if you can do me a favor and just check on that, that would be fantastic.
Can you see those on the screen now?
No, we cannot see what has been sent to you privately, but if you could read the question.
Sure.
To folks so they know what the question has been asked, and then you can answer it.
Okay, so the first one, it talks about the PMP registration for all physicians are recommended. We answered that one. And then it talks about where it is required. So, and Connie, this might be something that you can help me with. Are there any exclusions for new providers starting with the practice to give them time to get through the EPCS identification proofing process? I.e., could the new provider print the controlled medication prescriptions until they're set for EPCS?
Can you hear me, Lynn?
Yes, I can.
Okay, good. To the best of my knowledge, as I understand it, there is no, you could, I imagine, write a handwritten prescription and send it to the prescriber, to the pharmacy with a note on it that you have not yet been set up on your system, which I would assume would fall into the same category as your system being down at the time. So I believe, yes, that would be acceptable. If you read the letter of the law, however, it would not be acceptable. But I do believe it would be acceptable simply because others at that facility probably are set up and e-prescribing. Would you agree with that, Lynn?
Yes. When you talk about the letter of the law, when it says not operational, we had this come up a lot at the first of the year when we had folks who had sort of procrastinated and didn't have it set up yet. There were instances where that prescription was not filled because even though it wasn't operational, but the letter law, they just didn't have it. So I would highly recommend that you get it set up as quickly as possible so you don't run into that because that prescription could be denied.
I agree.
let's see here.
So, Lynn, I think there's some questions that are coming through, and perhaps they're coming to you privately as well.
Okay.
So, if the system isn't technically down just for a provider, can you elaborate a little bit more about what clinical directors can do if the system may or may not be down, and how someone can receive their prescription? I think there's protocols in place, if I'm correct.
It would be, so, and Connie, you can help me with this. When we get into this type of situation, because I work for the Board of Pharmacy, I don't really have a say in what would happen or not happen. I just sort of say what the law is. I think we've said where people actually just didn't, and remember, this is only for Schedule II opioids. So it's a very narrow, window of all the controlled substances. Folks have just haven't used controlled Schedule II opioids. So one of the ways that you can get, not have that problem. Connie, can you add anything to that?
I think you're bang. When I talk about it, I also quote the actual mandate in Bill 2075. I always say Schedule II controlled substances that are opioids, and that's the way it's written. So it is only the opioids, as Lynn said. But I think what you said, I agree with.
Okay.
Yeah, I think and I apologize to try and clarify the question. If another provider who is set for EPCS could prescribe the medication until the new provider is set, this is their worst case scenario now. I'm not sure if that's meant to be more of a question or just a statement to try and understand how to submit that prescription to the pharmacist.
It's a challenge, and when I hear something like that, I would be hesitant to say that, because I believe when you are prescribing, you have to have that patient-doctor or relationship. And again, this would be a great question for your licensing board, to be honest with you.
Lynn, I can add a little bit to that.
Okay.
I do know of several docs that are close to retirement that are maybe only seeing 10, 15 patients a year. And unfortunately, most of those patients, because of they're probably elderly as the doctor is, are required to, they're using the Schedule II that are opioids. So they're required to do some sort of prescriptions. If they can work with another provider, for example, of one doc whose son is also a doctor, they practice together. So actually, the patient is in both of their is in their system and has been seen by their practice. Only the younger doctor is actually doing the prescribing. I believe that fits the bill, because both of those doctors work in the same practice and both have been possibly seeing the patient, but at least they have the patient's information in their electronic health system.
Yes, this would be something that you would want to reach out to your licensing board to get an explanation on that.
I totally agree.
And Christine, I did get the question from Chris Bond, so I think we're good with.
Oh, okay, perfect. Wonderful. The chat box is open for those that are wanting to ask questions to Lynn Curtis, as well as Connie Ide, who's also on the phone with Health Current, who also provides EPCS webinars that we've held before. And we can leave that chat box up for another couple minutes. If folks have those, please go ahead and post them and we'll get your questions answered.
This is Connie. While we're waiting, I want to thank Lynn very, very much for another great presentation. Very informative. He always covers everything. You're a wealth of information. And I thank you for helping support the electronic prescribing of controlled substances initiative. So we'll leave the chat box open for Christine decides to close it.
Thank you, Connie. It's always a pleasure to be a part of this, and it's very. I'm glad that I'm able to impart information that's useful to folks. I know there's questions that are not answered, but we'll get through it.
Yeah, Lynn, there's another question that popped up. Can providers with a DEA outside of Arizona prescribe in Arizona? I'm assuming that's a DEA number. Not trying to stump you, but if we need to follow up on that question, we certainly can.
And you know, I apologize because that would be a question that would need to go to the medical board. I'm sorry.
Okay. Looks like they may have had a doctor, a local ED doc, and that's why they were posing the question. But we can certainly circle back around.
There, as regards to the PMP, there are doctors that are outside of the state of Arizona that have access to it. If you are, let's say that you work in Colorado, you can have access to the Arizona PMP, but you will only be able to see Arizona's information. So if you're, let's say you have two licenses, you have a license in Arizona and you access the PMP, then you would be able to access all of those 36 states that I talked about. So I can answer for the PMP side of things. But when it comes to the prescribing and the licensure for that, you'll have to ask the appropriate medical board.
Wonderful. Well, we are at the top of the hour, and I'm not seeing additional questions come through at this time. Thank you so much, Lynn, for your time. Oops, looks like we have. We'll take one last question if you can.
Sure, absolutely.
So, this is I think just a conversation for attendees, but another attendee said they did have a locum provider, not from Arizona, and they needed to do the EPCS identity proofing for them to prescribe the electronic controlled substance. So thank you for that.
Thank you.
There, so much appreciated. And with that, we are going to close the chat for today. Thank you again, Lynn, for presenting. We really appreciate having you on these calls and sharing your insight. Connie, any final words as well? Okay, wonderful. Well, thank you.
Get me off mute here. No, I have no final words other than to thank you and Lynn for making this presentation possible.
Wonderful. Thank you so much for everyone joining today. Again, the slides will be coming out to you once I receive them from our presenter today. We'll get those out as well as the recording today posted up to the Health Current website. Thanks very much, folks. Have a great afternoon. Stay safe out there. Take care.
Thank you, everybody.